Looks like we've got a packed audience here today. I'd like to thank everyone for coming today for the presentation. We're very lucky and fortunate to get this space and happy that everyone's free to come here for the lunch and enjoy the experts giving a talk on the Augmentic SpaceOAR device. We're going to present on the present and future role of hydrogel spacing in the treatment of prostate cancer, looking at both the 3 and 5 year quality of life evidence and SBRT experience. My name is Rod Ellis. I'm the Vice Chair for Radiation Oncology from University Hospital's Cleveland Medical Center at Case Western Reserve. I have the fortunate honor of being the first person in the United States to be able to use the SpaceOAR device once it was FDA approved and participate in the pivotal trials that got the FDA approval. So we're excited to have some experts here today to tell you about the device, show you the evidence, and tell you where we think it's going in the future. So without further ado, I'd like to introduce our first esteemed colleague, Dr. Michael Zelefsky. He's going to talk onto the experience with the rectal SpaceOAR for prostate SBRT and brachytherapy from Memorial Sloan Kettering. So Michael, if you would come on up and take the podium, we're honored to have you join us.
Thank you very much, Rod, and it's a pleasure to be here to discuss the role of the hydrogel spacer, and specifically I'll be sharing with you our experiences with its utilization for SBRT and as well for brachytherapy, and in particular for patients who are getting combined modality approaches such as brachytherapy in combination with external beam radiation. And so we're really talking here about broadening the applications, and we'll certainly hear from Dr. Hamstra regarding the pivotal study which utilized spacer and demonstrated its efficacy in a randomized trial in patients who were receiving conventionally fractionated external beam radiation. And it's certainly a very attractive scenario utilizing this kind of an approach when even pushing the dose intensification to the next levels, such as stereotactic body radiosurgery, and when combining external beam and brachytherapy. And we all recognize as well that with dose intensification, there is a greater risk for associated proctitis, and we need to do something about that because we recognize the importance of dose intensification in improving local control, and the barrier is normal tissue tolerance. So let's get to a question which many people really ask, which is, well, we have IMRT, we have IGRT. Is rectal bleeding post-radiotherapy in these instances a real concern? Or we don't really need anything to protect the rectum because we are doing so well? And so if you look at moderate hypofractionated phase 3 trials, and these are the 4 very important multi-center trials with median follow-ups of 5 to 6 years, you can see very clearly that late grade 2 plus GI toxicity is indeed a significant concern. And while these are not extremely high, and we're not talking about grade 3 toxicities or fistulas, there is grade 2 toxicity in these patients where we are employing dose intensification. And at the same time, while these studies have demonstrated non-inferiority for the moderate hypofractionated treatment schemes compared to conventionally fractionated radiation, just look across the board here. We're talking about grade 2 plus toxicity in the 15 average to 20% ranges. That affects quality of life. The ASCEND-RT trial, which all of you know, where most of these patients were even high risk, 2/3 of the patients were high risk, an extremely important trial demonstrating the benefit of combined modality therapy, a brachytherapy combined with external beam radiation. And I would say if there's anything that has given pause to people accepting combined modality therapy, it was the published toxicity rates associated with the combined modality therapy, albeit that the PSA control rates were significantly better, and that's undisputed, with the combined treatment. It's a form of dose intensification. And what we recognize is that 9-year PSA outcomes significantly better by at least 20%, and that's long-term data. And when we look at specifically GI toxicity, grade 2 and 3, it's a significant concern. So with dose intensification comes the possibilities of improving our local control for the patient, but at the same time, we recognize, especially for the combined modality group, as you see here, that 31% for grade 2 toxicity and grade 3 toxicity, 8%. So these are in general, the treatment interventions where we use the hydrogel spacer routinely at our institution. It's for SBRT, ultra hypofractionated approaches, and for the combined modality approaches as well, combination of brachytherapy and conventionally fractionated IMRT. We completed a phase 2 study where we are combining brachytherapy with SBRT of 5 grave times 5. Marissa Kohlmeyer was the PI at our institution at this study. And those results have demonstrated also not only efficacy, but a well-tolerated treatment program. Salvage brachytherapy, which is emerging as a real option and was reported by Juanita Crook as part of the NRG trial, demonstrating also that this is a real option for radiation oncologists to use. And I think if we can do anything to reduce the volume of rectum exposed to the higher doses, it certainly makes sense. And here's an example of a patient who had brachytherapy, and immediately after the procedure is where we placed the spacer. And you can see, and just eyeballing it, that we are talking about significantly reduced dose levels from a palladium seed implant to the anterior rectal wall. I'll share with you our recent experience with the hydrogel spacer for those undergoing LDR brachytherapy. There's a group of patients, 79 patients, who underwent brachytherapy and had spacer placement. Monotherapy in 33%, and combination with external beam, 53%, and about 15% of the patients were treated as part of a salvage brachytherapy approach. The average separation achieved between the prostate and the rectum was over a centimeter, 11.2 millimeters, with a range that went as high as 1.5 centimeters or more. The mean rectal volume receiving 100% of the prescription dose, demonstrating efficacy here as 0, and the mean dose to 1 cc of the rectum and to 2 cc of the rectum, 25% and 20%. And from all of the data, we know how the volume of rectum exposed to the higher dose is a very important factor, and clearly we are reducing that here. When we look at the various parameters and we compare it to a group of patients who we previously treated prior to the availability of the spacer, and these were 6 consecutive patients treated without the spacer, with brachytherapy and with or without the hydrogel, you can see, again, it's a retrospective comparison, but for the rectal V100, the rectal D1cc, and the rectal D2cc, significant reductions compared to a group of patients who did not have the spacer placement. You can see this based on the color wash, how we are really reducing the volume of rectum exposed, and even in the moderate dose levels as well. And while you may imagine that you may not need it with well-developed techniques, but anything we could reduce in terms of the volume of rectum exposed should be a benefit for the patient. That's been demonstrated now in the randomized trial, which we'll talk about later. And a similar concept here, again, reduction of the volume of rectum exposed to those high doses. And when we look at toxicity in the group of patients that we treated with the spacer, in these 80 patients or so, as far as grade 2 toxicities, Rectal discomfort is a low likelihood. And rectal bleeding, 2 patients reported. Most of these were hemorrhoidal in nature. And so these combined, if we focus on LDR and EBRT, we're seeing really lower toxicity profiles than what has been observed in the ASCEND-RT trial. So it's clear that that not only is it well tolerated, but potentially it's improving the tolerance profile of patients receiving dose intensification therapy. So my conclusions would be dose intensification has been shown to be an important aspect for the treatment of high-risk disease in particular and intermediate risk disease, yet treatment-related morbidity may develop, and that has been a clinical concern. The hydrogel spacer consistently results in significantly reduced rectal doses, and I'd say it's an important benefit for patients who are receiving, in particular, ultra-hypofractionated regimens, as well as combined brachytherapy with external beam. The early results demonstrate minimal late toxicities, as I've shown you. And I think a concept that I'd like to get across to the audience is that the mere reduction of volume of rectum exposed to the high dose, which has been a concept that's been played out there in the proton world as a potential benefit because of the reduced volume of rectum. This may allow us to achieve that, and who knows, in the next 10 years, we may be seeing less rectal secondary cancers as a result of reduced volume of rectal exposure from the dose of radiation we would give. Thank you very much for your attention.
We're going to hold questions till the end, but I'd like to bring up our next speaker, a man who needs no introduction when it comes to SBRT, for who the term Timmerman-like doses have been produced. I would like to bring Robert Timmerman up to the podium to speak on his experience with SBRT using SpaceOAR, please.
Okay, thanks. Uh-oh. Oh, here it is. Well, thanks for inviting me. And so I would like to talk to you a bit about our experience, which has been published now, but also about the future and how these kinds of interventions might be meaningful to our patients. First, some impressive prostitution, including spacers provided for our trials from Augmentics. At UT Southwestern, we have a history dating back to 2002 with regards to prostate SABR treatments. When we first started doing preclinical work, I applied for some grants, rejected many times, but eventually got accepted for 2 grants that ended up being the initial experience, a clinical trial development award and a clinical trial award from the DoD. We completed the first phase of that trial, the phase 1 study, in 2009 and published the results in the JCO. Then we completed the phase 2 trial in 2011. And at that point, we did a self-imposed moratorium because we were sort of in no man's land, not knowing how the late effects might impact the overall treatment effect. And so we didn't treat a single patient from 2011 to 2016 as we awaited toxicity. And at that point, we published our 5-year outcome data, which I'll show you briefly. And then in 2017, we partnered with Memorial Sloan Kettering to do our first spacer trials in SBRT, and that enrolled phenomenally fast for that trial. Our philosophy was, frankly, that we were more interested in how patients with high-risk disease could benefit from a therapy. Low risk certainly has many options, including nothing, that work well, but high-risk patients are dying of prostate cancer. We felt strongly that we needed to find a more potent treatment than just external beam treatments, even with androgen therapy. So we wanted to do a more potent dose, which meant we had to find the true boundaries of what these therapies could achieve and yet not be too toxic. So phase 1 testing was our impetus in order to get to the high-risk patients. And we felt strongly that people shouldn't just pick doses, that the dose ought to be based on a therapeutic window of looking at both efficacy and toxicity. Otherwise, we get this religion of what dose is the best based on what expert picked it. And in 2002, when we started this, we thought for sure the prostatic urethra would be the dose-limiting structure. It's right through the middle of the target. And it just goes to show how important it is to do prospective trials, because we couldn't have been more wrong. So the 2006 trial was opened at multiple centers, including my hometown. And we placed 3 gold fiducials. The enemas turned out to be incredibly important, which is obnoxious, but feasible if it's only 5 treatments. Would be very obnoxious for more. And I think in the end it was an important step. We also used a rectal balloon for our initial experience, trying to push the posterior wall of the rectum away. Mind you, there was no spacers at this time. And we no longer do that, and the patients are quite happy that we no longer do that. And then we used all the bells and whistles of IMRT and image guidance that we could use to use many beams or arcs. And again, we were concerned about the urethra, so most of our effort was to try to spare the urethra from the highest doses. And then the rectum was pushed away by the balloon. And so the 5-year results were published in this journal. And as you'd expect for an ablative treatment, the PSA control rates are phenomenal at long-term follow-up. But we did and reported toxicity to the anterior rectal wall. This is what you expect to do from phase 1 testing, because you're trying to find the boundaries of the toxicity. The only way to find boundaries of toxicity is to exceed the toxic dose. And so we did, and then we analyzed it as much as we could and figured out, I think in the end, and have published this now, where we went wrong in the few patients that did have grade 3 or higher toxicity. And honestly, I think we could avoid this if we were to do this trial over again, but that's of course hearsay. But if you treat more than a third of the rectum to 39 gray, the clonogens can't migrate to the front of the anterior wall where the superficial ulcers are to heal it. In addition, if you treat more than 3 cc's over 50 gray to the prostate to the rectal anterior wall, there won't be a vascular supply to feed those clonogens once they get there. So these were important things to know, but then along comes the spacer, and it seems like the problem is solved because we can just move away from this high dose region with the dose. And so if this was what it would have been without the spacer, hitting the anterior wall to 50 gray, and then we put the spacer in, that dose just ends up dumping into the spacer rather than the rectum, and it seems reasonable. The way we place the spacer institution, we use primarily local anesthesia, and most of them now are getting placed in the department. We started out in the hospital with general anesthesia. We're kind of over that. We trained 2 of our radiation oncologists, Mike's trainees, who if you walk by them, they're going to try to stick a needle into you, because at Memorial, apparently that's just their nature. But they like to put in the spacers. They do a great job. We also have 5 urologists. It's been well tolerated, just some complaints of rectal fullness after the procedure. As you know, it's biodegradable, so it'll go away with time. And then we engaged Mike to do this trial in 2016 with Mike Folkert being our PI. And these were low and intermediate risk patients, and the dose was our lowest dose on our phase 1 study, 45 gray and 5 fractions, because at least at this time we don't see a dose response for this group of patients. The rectal spacer, and the primary endpoint was toxicity, namely, do we get that ulcer on the anterior rectal wall that we saw in all patients when we treated without the spacer, which healed in 95+% of the patients, but in some it didn't. This paper will be presented as a late-breaking abstract, I think on Wednesday, so you can look at those results. In the technical aspects, we are now using MRI as much as possible in all patients to allow us to accomplish many things. We're still using those 2 enemas, which I think is probably the best pearl I'm giving you today, is to use 2 enemas before each treatment and simulation. We no longer use a urethrogram, and we no longer use a Foley catheter, because both of which are uncomfortable and cause deformations that are not useful. And instead of filling the bladder through a Foley catheter, we just give them IV contrast, have them walk around a while. The contrast goes into their bladder, and now we can see their bladder. And so we're finally doing the trial that I always wanted to do, which is the high-risk trial. Rakibul Hanan is the PI, so this is for high-risk patients. We're using 9.5 gray to the prostate and seminal vesicles, and our plan is to escalate, if possible, all the way up to 11 gray, because we feel like this is what high-risk prostate cancer needs, this deadly cancer. We are treating the pelvis, which I'm not thrilled about, at 5 gray times 5, and that can be debated. But the rectal spacer is important, particularly since we're not going to be able to spare the seminal vesicles. So you want to treat as little volume as possible with these therapies. And the primary endpoint is toxicity. I just want to take you back. When I was in training, we treated all the intact prostates. The surgeons didn't have a big share of prostate cancer patients at that time. I was at Johns Hopkins, and Pat Walsh became the chairman at our institution, and he started inviting urologists from all over the world to come into his operating theater to learn how to do this new procedure that he called nerve-sparing prostatectomy. And it was a big deal because he tapped into the fact that this is really important, even to these older patients that have prostate cancer, to spare their quality of life with regards to sexual function. And after that, Pat Walsh did this nerve-sparing prostatectomy. We all saw a huge migration of patients from radiotherapy to surgery, to the point now our residents see very few intact prostate cancer patients. So the radiotherapy departments, as far as prostate cancer, ended up being ghost towns, and the surgery indications just kept expanding, even to high risk. So the sexual function is very important after therapy, and here's the nerve-sparing prostatectomy's data as presented in these 2 published articles. As you can see, it goes down and it pretty much stays down. Not much difference between a nerve-sparing prostatectomy and a non-nerve-sparing prostatectomy. And if you plot on that the radiotherapy results, we are better than them and better than they've ever been. And so this is about marketing. Pat Walsh was an expert at marketing and was able to shift huge numbers of patients away. Fortunately, the groups from Michigan, including Dr. McLaughlin and Dr. Spratt, have helped us understand better where is the controls for ejaculatory function and erections in this anatomy. And so we have a much better idea of what we need to spare and how it should be spared. So the next step, I think, is to do nerve-sparing SABR treatments. And what we'll do is we'll make sure that the patients initially have potency, of course, and that we can spare at least one of the neurovascular structures, and that we make sure by MRI that there's no tumor next to that neurovascular structure. So all these tools that we didn't have back in the 90s will become useful. Now, if you don't put the dose in the neurovascular structure, you have to put it somewhere. And we're going to dump it in the spacer. And so this is something that I don't think could be done without the spacer. And so as you can see, we're pulling it out. So Neil Desai, another one of Mike's graduates, is going to be the PI for this trial. It's going to be a randomized trial, phase 2 randomized trial of giving prostate SABR either with or without nerve sparing. And I think this is actually going to be a really, really big deal moving forward, and we're going to hopefully have the same effect that Pat Walsh did with the nerve-sparing prostatectomy. So thanks for your attention.
That was awesome. Thank you very much. We're going to keep us on time. We're going to move forward, and I've invited my colleague Dan Hamstra up to help me publish many of the articles that we got out of the pivotal SpaceOAR trial. So Dan, I'm going to turn the podium over to you to let people know what we found on the trials.
Thank you. All right, so how do we do this here?
You have to go down to the bottom and then find yours. Should be, there you go.
All right, so thank you very much. And then, so here are my disclosures, including I have been worked as a paid consultant for Augmentics on this trial as well. So for those of you not familiar and those of you who are familiar, this is the randomized trial that was performed. It was for low and intermediate risk prostate cancers with the exclusion criteria indicated there in the lower left. Patients were randomized 2-to-1 to SpaceOAR versus control. I think an important point is patients were blinded to randomization. They went in the OR and they had a procedure. They either had markers placed or they had markers plus SpaceOAR, and they were not told what arm they were on until after the trial was over, so years later. Patients were then treated with what was conventional radiation therapy at that time, 79.2 gray and 1.8 gray fractions to the prostate. They were allowed to treat the seminal vesicles if they wanted to. PTV margins were 5 to 10 millimeters. Hormonal therapy was not used. It's also important to note that all of these plans were reviewed centrally at WashU at the Physics Quality Assurance Lab there. The patients were followed at 3, 6, 12, and 15 months, at which point in time 97% of the patients were still in follow-up. There was then an optional extended follow-up through April of 2016. This was optional by institution, and so not all institutions participated. Participation of patients at the institutions that participated was very high, but obviously some institutions didn't participate. And then what I'm going to talk about predominantly is the quality of life data. The EPIC 50, a standardized, probably the international standard questionnaire for quality of life at many places, was collected at baseline, 3, 6, 12, 15, and then at 36 months on the extended study. So what did we find? Well, the first thing we found was it reduced dose to the rectum. This was really the primary hypothesis. This was specific aim 1A of the trial. And specific aim 1A was deemed to be a success if there was at least a 25% reduction in V70, and there was actually a 78% reduction in V70. So clearly, the primary specific aim was met. Every dose we looked at, from 50 gray up to 80 gray, was reduced, and the relative reduction was greater as you got to higher doses. Then we looked at toxicity. That was actually the specific aim 1B, was a reduction in grade 1 or greater rectal toxicity using the CTC-AE version 4.0. And there was a reduction in both grade 1 toxicity here on the left. Statistically, this was a 75% reduction in grade 1 toxicity with rates of 9% versus 2% at 3 years. And there was also a statistical reduction in grade 2 toxicity with rates of 6% versus 0% in the SpaceOAR arm at 3 years. Obviously, no hazard ratio for the grade 2 toxicity when you have 0 events. So again, that was the secondary primary aim. So both primary aims were achieved in this trial. The initial data was published in 2015, and then the follow-up data here was now published in the Red Journal last year. Quality of life, as I noted, was a secondary endpoint. This was planned as part of the analysis. The EPIC was collected serially throughout. And this is the bowel quality of life as an average summary score over time. And so what you can see again here in gray is the hydrogel arm, and in blue is the control arm. And over time, there is a separation of these two. This is statistically significant throughout the entire time period. And more importantly, when you look at the late time points, first, the quality of life in the control arm is really quite good. A reduction of EPIC bowel summary score on a 0 to 100 score of 5% is actually 5 points is actually quite good compared to many other published series out there. But the experimental arm essentially had stable function, and so there was a difference between these two arms of 5.8 points. That meets the threshold for a minimally clinically significant change on this instrument. So what you can say is the average patient had a clinically significant difference. Now, quality of life and toxicity are not necessarily the same thing. So this doesn't say that the average patient had toxicity or the average patient showed a difference in toxicity, but statistically speaking, the average patient had an improvement in quality of life. We then looked at the percentage of patients that had detectable changes, because frankly, many of the patients in both arms did not have detectable changes. And so what you see here is men over time in the control arm in blue had anywhere between 30 and 40% chance of having a detectable decline in bowel quality of life that met threshold for a clinically significant change. And in the experimental arm, this was more in the 15 to 20% range. So a 3 to 4-fold reduction in the likelihood of a clinically significant decline in bowel function. And then if you look at twice that threshold, instead of looking at 5 points, you look at 10 points, you again see a separation of these curves. This was actually not statistically significant over the entire time period of follow-up, but was at the 3-year time point. And again, about a 3-fold reduction in the likelihood of men having a greater decline in quality of life here of 10 points, which I might argue probably starts to approximate something that you might call toxicity. By the time you have this level of change in your bowel function, it's probably more than just detectable. It's probably significantly bothersome. Now, urinary quality of life was collected on this trial. I will admit it was not anticipated that urinary quality of life would be different between the arms. And in fact, the average urinary quality of life was not different from baseline up until the final time point. At the final time point, there was a slight difference in urinary quality of life that was statistically significant. Essentially, the control group had a 3-point decline versus stability in the SpaceOAR arm. This difference of about 4 points, however, although statistically significant, doesn't meet the threshold for a clinically significant change. So I think what you can say is the average patient, in terms of urinary quality of life, did not appreciate a clinically significant change, which is different than the bowel quality of life. Now, again, we looked at the proportion of patients meeting thresholds for a clinically significant change of 6 points here in the urinary domain on the left, or 12 points, twice that on the right. And what you can see, these are the data at 3 years, is that for both of them, at 3 years, these differences were statistically significant. So 30% of men had a detectable change in urinary quality of life on the control arm versus 17% of men on the experimental arm. And for twice that, 23% of men on the control arm had a detectable decline of urinary quality of life of 12 points versus 8 points. Now, the lower risk, the 6-point decline, was really only statistically significant at the final time point. I'm not sure how relevant that actually is. Interestingly, the 12-point decline was actually statistically significant throughout the time period. So you were potentially in some ways helping to avoid the worst toxicity in terms of urinary quality of life on this trial, albeit for a relatively modest portion of patients. Why was urinary quality of life better? I don't have a mechanistic answer. I can tell you what we looked at with the core lab. We looked at the prostate doses, homogeneity, hot spots. We looked at the bladder. We looked at the bladder wall. We looked at the penile bulb. And we looked at both the intraprostatic and extraprostatic urethra. We did not find significant differences in dose for any of these structures except for the penile bulb. And there was no difference that correlated dosimetrically with the urinary quality of life. So I don't have a good answer for you for why urinary quality of life was different on these two arms. I have two hypotheses. I will say that my first hypothesis is really the I dare you to poop without peeing effect. I think if these guys are having more problems with bowel movements, literally if they're in the restroom, they're going to urinate more, and they therefore may complain about urinary frequency more, urinary issues more, simply because they have worse bowel quality of life. I also think there's a certain amount of, well, I'm already pissed off effect. You know, when they're filling out the quality of life questionnaire and they say, gosh, I have problems with my bowels, I have problems with my sexual function, and this is how much I urinate, and they ask, how bothered are you by that? They're kind of ticked off, and they say, yeah, I'm bothered by that. And if they aren't bothered by urinary function, by bowel function, and they aren't bothered by sexual function, and they report their urinary function, they say, how bothered are you by that? They may not be very bothered by it. So I think it is possible that you're getting a comprehensive improvement in quality of life such that relatively modest changes in urinary function do have a more quality of life impact for the patients. The sexual quality of life, I am running out of time here, so I will just show it very quickly. This was actually published in Practical Radiation Oncology on Friday, so anybody that wants to see it can get it. You know, the take-home message is this. Penile bulb doses were lower. They were lower at every single dose all the way through the patients. They were statistically lower in these low ranges, the V10 to the V30. They were also lower for the Dmax and the mean dose. The ability to maintain an erection, the ability to maintain the same erectile function over time, here for all patients, irrespective of arm, was better. So if your V50 was lower than 20%, or if your mean dose was lower than 23 gray, these are both cut points taken from an analysis of the CHIP trial, so these were not searched for in this data. We used published thresholds. In both these cases, if you had a better penile bulb dose, you were more likely to maintain your erectile function. However, if you looked at the randomization, there was no difference. Why was there no difference? There was no difference because sexual function on this trial was bad to begin with. This is the PROS-QA data for comparison. They were much better. So if you looked at the patients who had poor sexual function, an EPIC less than 60 to begin with, there was absolutely no difference by randomization. However, if you looked at the men, only 41% of them who had an EPIC greater than 60, now you start to see a difference, albeit a p-value of 0.07. This difference, borderline in statistical significance, but actually met the threshold for a clinically significant change of 10 to 12 points. If you look at the individual items within the EPIC, there are 13 items in the sexual domain. 12 out of 13 favored the SpaceOAR arm, and 7 out of 13 were statistically different. So this is the proportion of patients with a moderate or severe change in sexual function or sexual quality of life. So why was the penile bulb dose lower? I actually don't know that either. We are starting to look at that. Again, I think what it amounts to is kind of like Bob was saying. Dose has to go somewhere. And if the planning system is trying to optimize rectal dose, it can't meet secondary goals like the penile bulb. And as soon as the planning system can easily achieve a rectal plan, it can start to address secondary goals like the penile bulb. So I think that's probably why the penile bulb and probably some of the structures that Dr. Timmerman alluded to were spared, and we're going to look at that in the trial using the plans from the case. So I'm going to stop there. I'm not going to go through the conclusions. As noted, both of these papers are now published, one in the Red Journal in 2016 and one in Pro just this week. Thanks so much.
Yeah, it's amazing to hear these speakers talk first about the future opportunities in SBRT and also just the rich data that was acquired by this Augmentics trial. It was amazing how well that trial was run and the information that is provided. Now the question is that reproducible data? And we're very fortunate to have a world expert coming to us from Bonn, Germany, Dr. Michael Pinkawa, who's got 5-year data on the patients in his clinic showing this is reproducible. So I welcome him to the podium to talk about his experience with SpaceOAR in Germany. Thank you very much for coming.
Okay. Thank you very much. Thank you for the invitation, the possibility to present the 5-year data. So in contrast to the randomized study, our patients are within an observation study. So we have 2 cohorts of patients that were treated within the normal clinic. This is an evaluation of the first 2 years. So we started with SpaceOAR in the year 2010, treating about 25 to 30 patients within this concept of treating only the prostate with an IMRT technique, 2 gray fractions up to a total dose of 76 grays, and in some of the patients also within this period of time 78 gray. So in total in this analysis we have included 54 patients with a hydrogel injection and 60 without a hydrogel injection. Patients were included. Selection criterion was simply the physician's or patient's preference for treatment with or without the spacer, because at this time we had no data, no clinical follow-up data for spacer. And we analyzed quality of life at specific time points, starting before treatment and several time points after treatment. And as we heard in the last talk, the clinically significant threshold was 5 points. Here we can see the baseline characteristics of these patients, and we can see that they are really similar, comparable, considering the age, PTV, PSA, the risk groups. So it appears like a randomized study, although it wasn't really randomized. And the most important point, the focus of this analysis is the bowel function, bowel quality of life. And here the most important difference is the dose to the rectum. In this table, the percentage of volume within the 90% isodose, so this is about 70 gray. We can see that the dose is significantly reduced from mean 13 to 4% or median 12 to 2%. So these are the results summarized in one table. We can see at the upper part the 1.5 year results, and the lower part 5-year results with a urinary bowel sexual bladder score changes. Negative score means an improvement. Positive is a decreasing quality of life. And in the brackets, you see the quartiles. So you can see at both times, 1.5 years at 5 years, that we in the urinary domain, there is no decrease. In contrast to the randomized US study, we don't see a difference, or a really significant difference between the groups with or without hydrogel. But in the bowel scores, it was also the same observation that in the acute phase we didn't see a difference between the hydrogel and group and non-hydrogel group. But after a longer follow-up, we see a difference of more than 5 points. So we can see that without the spacer, there's a decrease in quality of life of mean 7 points and 6 points after 5 years. And it's really nearly nothing after with a hydrogel spacer. And we also see a difference, a tendency at least, for the sexual bother, that the hydrogel could slightly improve the sexual bother scores or decrease the change. And then another important point is the other specific items. So we didn't have a single patient with a spacer who reported a big or moderate problem with bowel habits or with bowel urgency, losing control of stools. And this was in both analyses after 1.5 and after 5 years. And we had also the same observation in our analysis of the first 100 patients after 1.5 years. That is, it remained 0. So considering the changes larger than 10 points, it's also similar to the randomized study that we have, what we have heard now, that that we had significantly less patients who have reported where we found a decrease of more than 10 points. It was in 6 versus 32% after 1.5 years, and in 5 versus 14% at 4 years. More than 10 points would correspond to a moderate decrease of quality of life. And finally, the sexual scores, sexual bother scores. It's interesting that although this is again only a small group and a lot of patients were not potent before treatment, but at least we have, it's interesting that we also observed a significant difference for the sexual scores. So if we look at a percentage of patients who have reported erections firm enough for intercourse, there's a significant difference of 24 versus 3%. And also if we focus only on the patients who have reported erections sufficient for intercourse before treatment, we have a significant difference of 50% versus 0%. So to summarize, the first 5-year quality of life data results in a group of prostate cancer patients treated with a hydrogel spacer demonstrate excellent treatment tolerability, in particular regarding bowel problems. And further studies with dose escalated or re-irradiation concepts can be encouraged. So we can see that rectal toxicity is not a problem when we're treating with this concept, and we can carry on with treating with, as the prior speakers had told, we can carry on treating with larger fractions and carry on with dose escalation. Thank you very much.
I'm going to let you take a seat here. I'll call the other audience members up. So while I'm calling the other 3 audience members up to join Michael on the stage here, I'll take this moment to point out my observation is this is really incredible data that we're seeing. Not only can this be done in standard patients, we're seeing that it can potentially be reproduced in clinics prospectively, and it has an application in SBRT. We talked about the 4 studies, the pivotal studies looking at hypofractionation that have recently been published, showing that we can give larger dose protraction and reduce the number of treatments our patients get to get through treatment sooner. And we were just blessed by the NCI to get funding for GU005. So I'll be the national PI for the RTOG GU005 that's going to compare 28 fractions to 5 fractions with SBRT and does allow for stratification for rectal manipulation using SpaceOAR or a balloon or a combination or no rectal manipulation. So for all of you RTOG members, by a show of hands, I encourage you to accrue at least 10% of the patients onto the trial and join us as a co-author. So let's get this thing going. Let's open this up to the audience, though. Is there any questions from the audience before I go into some questions I can add in as well? It looks like we have one from the back here. If you'll step up to the speaker, make sure everyone can hear you speak. Thank you.
Yes, when I've inserted hydrogel, I've had a difficult time seeing the prostate after I insert the hydrogel in via ultrasound. If I'm doing 2 fractions of HDR brachytherapy, this is problematic. Do you have any tips to be able to see the prostate after you've inserted the hydrogel, or is it just not possible? Thank you.
Yeah, I would say one option, do 1 fraction. Another option is do CT-based planning. You can see the SpaceOAR relatively well on a CT. I mean, obviously you see it better on an MR, but especially early when the SpaceOAR has been placed, within the first week or so, you can see it a little bit better than you can over time. But you're right, you know, if you've placed a semi-fluid solid space between the prostate and the rectum where you're going to use an ultrasound, you're not going to be able to visualize well. So I think, you know, when you do LDR, for instance, most people, Michael can address it, you know, you do the implant first and then put the SpaceOAR in at the end. So it does make it problematic for doing HDR with 2 fractions.
Next question.
Have you seen any changes in the physical property of the spacer as a result of radiation, meaning any shrinkage in the spacer or changes in the separation from PTV to the anterior wall of rectum?
Actually, couldn't hardly hear you, could you?
Can you hear me now?
Perfect,
Yeah.
thank you.
I guess my question is, have you seen any changes in the physical property of the spacer as a result of radiation, meaning shrinkage or any changes between the anterior wall of rectum and the PTV, what you have seen before the start of radiation?
Are you asking like during the, like for cone beam CT, are you looking to see if there's changes daily throughout the course of treatment?
So does spacer has got any impact which is related to radiation?
Yeah, it's very stable typically in the first 90 days after it places. So as soon as the 2 agents go together and make the gel, they form a stable space.
Yeah.
But it does disintegrate then after 90 days. But up to 90 days is
Okay.
fair. It's very consistent in the first 90 days in the size and shape and the configuration of the space it takes. And they looked at that on the initial trial with repeat MRIs serially, looking at the effect. And it's not until after you get past the 90 days that you start to see the decrease.
We've seen this stability as well other investigators, as exactly as Dr. Ellis had mentioned. We've actually looked at as well in the series where we were studying patients who were implanted and looked at the differences of seed positions before and after the implant was done. And actually there are some small shifts of the seeds pushed as a result of the placement of the spacer. But interestingly, the dose to the urethra was not significantly higher with the placement of the spacer. So there clearly are distortions of the gland itself, but those distortions remain stable during the planning and treatment period.
Excellent, thank you.
And that data on the stability of SpaceOAR is in the Marianas publication from 2015. So if anyone wants to look at that, none of us, I don't think, have the numbers at the top of our head, but those volume calculations were in there.
What's your question?
I'm Nagin Shahi from BC Cancer Agency Canada. Thank you for the interesting talks. My question is about the rate of perforations or any complications due to using the spacer gel.
On the randomized trial, they did not see any severe toxicity from perforations or things like that. There had been, with SpaceOAR and with some of the other types of substances that have been injected, there were anecdotal cases previously. But I think if done appropriately as instructed, the likelihood of that is very, very small.
And I'll comment further on that. I think part of it's the training when you first start doing. You have to do the hydrodissection to open the space up. If you're overly aggressive with the hydrodissection, it allows the gel to open up to more areas. You can either get asymmetrical filling, extension into the seminal vesicles. We can talk more about that. I think Michael has a video. If we get time, we might get a chance to even look at that. So we'll see if we can share that with you as well. Next question.
But I would mention as well that some have reported rectal infiltration into the anterior rectal wall. We have not really seen that in our experience to any significant extent, but that has been published. So I think it's obviously very dependent upon technique.
Yeah, we're going to get into that as well.
Jason Hearn from the University of Michigan. Thanks for the excellent panel. I have a question for you about a technical issue that occasionally comes up in patients who have more locally advanced disease. So you have a patient with posterior extracapsular extension, let's say on MRI. Those patients clearly wouldn't have been eligible for the randomized trial because patients with ECE were excluded. Dr. Timmerman mentioned in one of his studies that includes T3 patients. For the panel's clinical practice, how do you approach such patients that have posterior ECE in terms of whether you're willing to risk potentially dissecting through it, let's say, and then sparing it aggressively if you have a gel in place versus some other approach that you have?
Yeah, I'll be curious what the rest of the panel says, then I'll add my comments because I've certainly had some experience with that as well. Go ahead.
Part of that is why we do these things on study. I mean, we'll see if we can see that it happens at the time of the placement, or if we see recurrences in areas that would be accounted for by what you just said. That being said, this trial that I was talking about has already enrolled patients just like you have said, and we're going to follow them and see how that goes. But it's the same issue, I think, in cervix cancer, where some people have wanted to use spacer in cervix cancer, but you could isolate an island of tumor apart from it if you do that. I think the fascia between the prostate and the rectum is going to be more helpful for us in creating this potential space to push it up with the prostate. But theoretically, what you said could possibly happen.
So if I could just expand on that, I think when you place the first needle and you're starting to hydrodissect, usually you get a pretty good feel whether the space is going to pop open well or not. I've seen some cases where I get asymmetric placement of my SpaceOAR, and I guess I'm okay with that, especially considering Bob's data where they look at the number of cc's get the high dose. Even if I only spare on one side but not the other side, it may be helpful. The concern and the risk is if it's a real stuck prostate, or you push it any cancer cells down as you hydrodissect through, and that would be the concern. So it's a clinical judgment. Again, the initial data, I don't think there's enough experience. I agree with Bob, we need more experience in this and we'll get more guidance. But I think as long as you're comfortable with the hydrodissection when it takes place, even if there's some areas where it sticks down and gets some asymmetry, it may still be helpful for the patient, in my opinion.
I think it's also important to mention that the initial indications for SpaceOAR, as you allude to, is really not in scenarios where there is any posterior ECE. And I think, as Dr. Timmerman had mentioned, these are patients that should really be enrolled on studies to evaluate that. So in those patients, we're cautious. But I'd like to highlight what Dr. Ellis just mentioned, that you're not committed to instill the spacer for every patient you see. We've had about 3 or 4% we had to abort the procedure because we didn't see that the hydrodissection was effective. And so you're only committed to instilling the spacer once you actually inject it. But I think the appropriate approach, at least the way our institution handles it, would be to see if you have an effective hydrodissection, and then that's when you have more of the confidence that you need to go forward.
Yeah, I had an example of a case that was a cryotherapy salvage that I was trying to do proton salvage, and I was unable to get the hydrodissection to take place, so we did not use it. We went in and attempted, but it did not open up, so we treated him without the SpaceOAR.
Thank you.
And I guess my personal opinion would just be, I probably would not treat patients with T3 posterior extension to the rectum, not on a clinical trial, because it's not something that we know. It's not been done.
Right.
So I think you're potentially offering patients a harm for, I think, a statistically significant and clinically meaningful improvement in quality of life, but you're in gray territory there, so I personally wouldn't do it.
Steve?
Steve Finkelstein, AUI. Rod, fantastic panel with Mike, Bob, Dan presenting excellent talks highlighting how important this is to our future as radiation oncologists. Can you each of you comment if there's any impediments you see to the successful implementation of this in the community going forward?
I'm not sure if there are significant barriers at this time, but certainly it requires skill to place, and it requires the interest to take the time to do it. There is a learning curve, but so certainly if there's a commitment to do that as part of a program, and we've heard today the potential benefit across the board, I certainly think it's well worth it. Number two, there's sometimes insurance issues that have been some barriers, but I think that has actually been improving over the last number of months. And I think with the emerging of more data we're seeing right now, and especially the randomized trial, I think these things will be changing for radiation oncologists in the future.
Yeah, I think the level 1 treatment code that was just achieved will help reimbursement issues with it. You know, I think I'm preaching to the choir, but I think as radiation oncologists, we're the ones that are going to get blamed for the rectal toxicity. I think if we allow someone else to place a SpaceOAR for us, we can do that, but if they don't place it well, we still carry the risk. And so I think it's a very simple procedure to learn. If you're comfortable doing brachytherapy, then you can certainly be very comfortable doing SpaceOAR. And even if you're not a brachytherapist, it's not a difficult procedure to learn, not much different than placing fiducial markers. And I would encourage anyone that's interested to learn the technique themselves, or at least train a urologist to do it well for them. I think there's one more gentleman with a question.
Thank you for presenting your research. I practiced outside Atlanta at Malay Rao. My question was, do you always contour the SpaceOAR when doing your treatment planning? Because as you mentioned earlier, if you do it within a week, which we do, at best you can see the SpaceOAR product so-so. So one, do you routinely contour it? And if so, would you get an MRI to identify it? And lastly, have you ever considered mixing the hydrodissection with some type of contrast agent to better identify it on CT?
Those are great points, and I know that Augmenix is looking at potentially making a product that has the ability to see that on CT scan, because it's not as clear. I always plan prostate with MRI, so I do always contour it from the MR and fuse that to the CT for the treatment planning. As we move into synthetic CT and MR-based planning, I think this may be a self-resolving problem. I don't know how anyone else in the audience feels about that.
We've exactly done that. Most of our external beam planning, almost all of it now, is done with actually MR simulation and MR treatment planning, and certainly others are doing a lot of MR fusion as well. So I think that's obviously where you see the clearest delineation of the spacer. In patients who have bilateral hips or significant cardiac stents are not MR candidates, we've exactly, as was mentioned, inject some contrast as well to see the spacer, but shortly thereafter on a CT scan. And as Dr. Ellis had mentioned, I know the company is exploring other approaches to make this more visible on CT.
How many people in the audience, by show of hands, have placed a SpaceOAR? That's pretty good. How many people are interested in learning how to do that? Any advice from the panel for people that are looking? I mean, would you prefer to see them start it out in the operating room, or do you think they're comfortable doing it in an outpatient setting with anesthesia, or just sedation, or how do you think they're best to move forward?
I think it's pretty clear that you should put the patients to sleep the first few that you do it, so that you can have open discussions with the people that are training you, and that the patient's not overhearing the comments that are made and things like that. Plus, there is a definite learning curve. None of our, either the urologists or the radiation oncologists that are putting these in were stellar at it when they first started out, and so they're going to fumble a bit, and the patient doesn't need to hear that or understand that that's happening, so I would put them to sleep for sure.
So lastly, I'll put a question out. You know, I think there's some patients it's very simple and straightforward to place the device. There's some patients where it's a little bit more complicated, whether they've had prior surgery or prior radiation, or there's patients that are on blood thinners. Has any comments from the panel on how to approach any of those three problems or suggestions for people in the audience as words of precaution?
There are clearly patients who've had, and the following scenario may be the ideal scenario to consider spacer, and that would be previously irradiated patients, prior seminoma radiation, for rectal cancer prior treatment. And we've noticed in some of these patients, I think, Rod, you had alluded to, that there is significant post-treatment scarring, and you're going to need to prove the area, so to speak, by using the hydrodissection to see if things open up for you. If they don't, you just need to be prepared to say, this is not the ideal scenario, and we're not going to simply inject the spacer material in. So I think you'd have to be prepared for that. There are challenges where you just simply can't predict. But I think in general, if you, with more comfort and more experience, most of the patients, you would not need to abort the procedure.
So one last point I'll put in. They talk about the SpaceOAR giving you space, and Michael and Bob, you both co-authored a recent paper saying it also provides some improvement in motion of the prostate. Compared to an endorectal balloon, do you feel comfortable saying that you don't require both, or is there a use for both? Like I say, on my trial, we're going to allow randomization and stratification to both, but I'm curious from the experts that have written that paper whether you feel that, you know, gas behind the rectum or anything else precludes or does still need the use of an endorectal balloon, or does SpaceOAR resolve these problems for us?
I mean, if you use the spacer, I definitely think you should not use a balloon, because you would sort of be deflecting rectal tissue into a concavity within the region of the prostate, which would not be helpful. So I think it's one or the other. I certainly wouldn't do both. And I think that our experience with the balloon was creating circumstances where the dosimetry wasn't as good. And so I definitely wouldn't do both. Not to mention that the patients really don't like these balloons, and that's meaningful.
Now, my experience since we opened up a proton center about a year or so ago, the Brotherhood comes to me and they ask for that balloon. So,
Yeah, well,
you know, for those of you familiar with the Brotherhood of the balloon.
Yeah. Now the thing about gas, though, you know, the prostate motion needs to be eliminated, and that way you can use a smaller margin. And our most recent analysis of the setup error with our prostate treatments revealed that we needed a 2 millimeter margin to treat 95% of the patients on a daily basis. And we were still too chicken to go to 2 millimeters, so we're still using 3. But that's because of the enema. The enema eliminates gas and stool that would be coming down the pike and banging into the prostate. And that's why, again, I feel so strongly about 2 enemas 30 minutes before the treatment.
And 2 enemas is good in Texas also, but it may be hard to do that, but I think that's actually a good idea that we would consider. Another aspect, some of the over-the-counter, simethicone, these gas X products, which we give our patients throughout the treatment, would reduce gas. But certainly the spacer is not going to eliminate the gaseous distension that obviously could change interfraction motion and the like. So whether it really reduces mobility of the prostate, I don't know. It's well established, and we're looking at it. I know one group in Australia has not shown any significant differences, but I think it needs to be studied carefully.
So one last question I'll ask of everyone in the panel. I think one of the concerns a lot of people have when they start placing this device is, do the patients feel any discomfort from the device or have difficulty with it? Certainly in my practice, I've not seen that. In the trial, it was a placebo trial where they were not told whether they got it or not. It was not something where people could walk out and say, gee, I can feel you place something there. Have you guys had experience with patients that had discomfort or difficulty because of the procedure?
We've seen patients who, and Bob has mentioned that, who have rectal fullness or some rectal discomfort, which is alleviated with anti-inflammatories, about 6 to 10% of the patients in our experience.
Any other words of wisdom from the panel to the audience members today before we take our closing remarks?
I think the concept of reduced volume of exposure of normal tissues is well established. I think the question that does come up is, does it provide a meaningful reduction in terms of toxicity? I think we've seen it especially from the randomized trial, and in particular in patients who have received conventionally fractionated doses to dose levels we've used now for over a decade. we're moving now, without a doubt, into era of dose intensification and combined modality regimens. And we've heard even at this meeting about some of the concerns in the ASCEND trial of the toxicity, urinary toxicity, but also rectal toxicity as well. So we clearly have an opportunity to utilize this. I don't see it as a downside, and I think we need continued studies to demonstrate in these specific scenarios, dose intensification, some of its benefit as well. And who's to know, as I mentioned, that we need to look at the secondary cancer risks down the road in terms of our ability to reduce volume of rectum exposed to our high doses. It may make a difference, and I think this needs clearly to be studied as well.
So my last comment I'll add is on technique of actually using the device. They talk about you should use a stepper to hold the ultrasound and do it in a lithotomy position. Initially it said either with or without a template. When I first started doing it, I was trying to do it like I was doing a prostate implant through a template. But what I found, and I'm curious whether the others in the audience or anyone that's on the panel would speak to it, is that without a template, I found it was easier to come in above the rectal tent and then angle my needle to dive down into the space versus trying to get that needle to drop into the space through a template. Has anyone else seen that exposure or that experience?
Yeah, I mean, I agree. We do it with a SpaceOAR to hold the ultrasound, but don't tend to use the template, and we put the template on after it's needed.
Okay, very good. I just want to give those tips to the audience if you're going to go out and try this at home. Thank you all very much for coming for the lunch meeting.